Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast both Dr. Núria Agustí from the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas, MD Anderson Cancer Center here in Houston, Texas. And then also David Viveros from the División of Gynecologic Oncology, Fundación CTIC in Bogotá, Colombia. And the reason for the podcast is we're going to have a discussion about a recently published article in JAMA Oncology titled Adjuvant Chemoradiotherapy versus Radiotherapy Alone for Patients with Intermediate Risk Cervical Cancer. Núria, David, welcome to the podcast. Always great to have you. And as we were previously discussing, you're both back from previous podcasts as well. So welcome back once again. Thank you for accepting the invitation.
Yeah, thank you so much for the invitation. For us, it's also a pleasure to be back here with you.
Yeah, thank you. Thank you. We are so happy to be here again.
Well, again, another impressive article from you both and your respective teams. And I want to congratulate all of the co-authors also as well who worked on this article. Topic of high relevance in our field of gynecologic oncology. So I wanted to start by discussing where we stand today as it pertains to the recommendations for adjuvant chemoradiotherapy versus radiotherapy alone in patients with intermediate risk cervical cancer. What do the guidelines tell us? And I'll start with you, David.
That's really interesting because even when we could think that the evidence is limited for considering chemoradiotherapy in patients with intermediate risk cervical cancer, the NCCN guidelines for those patients that meet a set list criteria recommends the use of adjuvant radiotherapy with external beam radiotherapy, and that's a category 1 evidence based, of course, on the UG92 trial, but it also gives the option of using concomitant chemotherapy, and that's for the guideline, category 2B. On the other hand, in the European guidelines, it suggests considering adjuvant radiotherapy for those patients, but it does not endorse concomitant chemotherapy. And for that guideline, observation is listed as an alternative option, especially for those teams that are experienced following that approach. This, of course, for us reflects that there is an evidence gap concerning the benefits and the optimal selection of adjuvant treatments for this population. However, as you could see in previous database studies, there is a high percentage of patients inexplicably receiving chemotherapy without an supporting evidence for that.
Yeah, and absolutely a topic of frequent discussion, debate when we are presenting these patients in our tumor boards. I'll turn to you, Núria. What do you see as the limitations of the current retrospective data evaluating this point on treatment of intermediate risk cervical cancer patients?
Yeah, so there are some limitations when it comes to retrospective data on this topic. First, many of the studies that have been done include a small sample size, and more importantly, it's not always clear what criteria they use to define intermediate risk. And of course, that's a big issue because some of these patients might have actually been high risk. And if you are mixing those groups, you might see differences in survival outcomes that are not really due to the treatment, but rather because you are not comparing, for example, apples to apples. And in fact, some studies even included patients who received multiple lines of chemotherapy, which obviously doesn't reflect standard practice for intermediate risk cervical cancer patients. One example that really stands out is another study using also the National Cancer Database. And this study didn't define intermediate risk group based on clinical criteria, but rather they grouped patients depending on the adjuvant treatment they received. So the analysis could have included both high risk and lower risk patients because the database doesn't explain why those treatments were chosen. And plus, that study also included patients before 2010, when the database didn't report key variables like LBSI or surgical approach. So all of that are some examples that might introduce major bias. And finally, if we look at what was the only available phase 3 trial, STAR trial, that compared sequential chemoradiotherapy versus concurrent or radiotherapy alone, even there we have some limitations, as the trial mixed, again, high and intermediate risk patients, and their definition of intermediate risk was limited to LBSI or deep stromal invasion, and tumor size was not even considered. And on top of that, over 80% of patients with tumors larger than 4 centimeters got neoadjuvant chemo, which is not part of the current guidelines. So between inconsistent definitions, outdated or incomplete data, and mixed patients population, it's really hard to really draw solid conclusions from these retrospective studies.
So then now, looking at all of those limitations, I'll turn to David. Let's talk about the methodology of the study. What was your study design? And if you can tell us also, particularly for our international listeners, a little bit about the National Cancer Database. What are the advantages and the limitations of that database?
Oh, sure. This study was a retrospective cohort study using NCDB, which is, a multi-institutional cancer registry. It includes only Commission on Cancer accredited centers, and it represents more than 70% of all newly diagnosed cancer cases in the US, but particularly for this study, it also includes more than 85% of patients with a new diagnosis of cervical cancer. For this particular study, we used multiple imputations to address the missing data across all variables to minimize bias. So we had 10 imputed data sets that were generated, and we used the mean values across all those imputed data sets. And after that, a propensity score matching was performed to obtain comparable cohorts. Regarding the advantages and limitations of NCDB, of course, it's so important for us because it represents one of the most comprehensive cancer databases available, and it features a mechanism that enables to have a continuous acquisition of high quality data. It also serves as a unique platform for assessing treatment patterns in patients with gynecologic cancers across the US. And particularly, it's so good for generate data that help you to formulate new hypotheses. Of course, the primary strength lies in the extensive number of patients included. There are various locations, histologic subtypes, and everything regarding variables that allow you for having meaningful analysis. And for particularly survival analysis, it also allows you to have long-term survival outcomes, and that's kind of difficult or even impossible to sometimes to obtain those from a clinical trial. And on the other side, of course, it has limitations. Like every observational database, it has patient selection bias because it only includes patients that are managed on Commission on Cancer accredited hospitals, and that requires them to demonstrate compliance with a certain quality metrics on cancer care delivery. And also, as the NCDB is based on hospital data, it does not aim to represent the entire US population, and of course, it also with the population from other countries. Maybe as an additional limitation, of course, we don't have info that we'd like to have, like genomics or imaging data, as well, of course, as missing information about recurrence for those patients or specific causes of death, making it impossible to have recurrence rates or disease-free survival or cancer-specific survival, and only overall survival as the main outcome of interest.
Very well. So, Núria, can you tell us about the patient selection and what was your primary and secondary endpoints for this study?
Yeah, sure. So for this study, we included patients diagnosed with cervical squamous cell carcinoma, adenosquamous carcinoma, or adenocarcinoma between 2010 and 2020. All of them had undergone radical hysterectomy with lymph node assessment as their primary treatment. And importantly, we only included patients who had negative lymph nodes and no distant metastases. After surgery, they must have received either adjuvant radiotherapy alone or radiotherapy with single-agent concurrent chemotherapy, regardless of whether brachytherapy was added or not. And we also excluded anyone diagnosed before 2010 because the NCDB does not collect surgical approach or LBSI before that year. And we also excluded patients with high-risk features, such as positive surgical margins and parametrial invasion. And finally, also a history of prior malignancies and those who received neoadjuvant therapies or multi-agent chemotherapy were excluded. As for how we define the intermediate risk group, we use tumor size and LBSI because, again, the database doesn't include depth of stromal invasion, so we classified patients as intermediate risk if they had tumors larger than 4 centimeters, regardless LBSI, or tumors between 2 and 4 centimeters with LBSI present. Finally, regarding the objectives, our primary outcome was overall survival, and that was defined as the time from diagnosis to death from any cause. And as a secondary objective, we aim to identify factors that were associated with receiving chemoradiotherapy, basically because we wanted to understand why some patients were receiving chemo and others, in fact, did not.
So now let's get to the results. David, what were your main findings? What would you like to highlight as the most important take-home points?
Sure. The most important result of our study was that the overall survival did not significantly differ between patients who underwent exclusive radiotherapy compared to those who underwent chemoradiotherapy. We also had the subgroup analysis of patients based on histology, LBSI, tumor size, the surgical approach, or the brachytherapy used, and there were also no differences. There was no benefit for any of those groups. Therefore, the key take-home message from our study is that given that the lack of benefit of concomitant chemoradiotherapy compared to external beam radiotherapy alone, we consider that the use of chemotherapy should be avoided in patients with intermediate risk cervical cancer.
Now we get to the questions from our fellows in the journal. Now, let's start with Matteo Marchetti, who is at the University of Padua. And Núria, I'll start with you. And Matteo asked, the study shows that chemoradiotherapy was more frequently administered in cases with non-squamous histology and tumors larger than 4 centimeters. Can we still consider the intermediate risk category as a clinical homogeneous group? More specifically, how do you think treatment decisions might change depending on whether 1, 2, or all 3 risk factors are present? Lymphovascular invasion, tumor size, stromal invasion.
Yeah, I think it's a great question. Honestly, I don't think we can consider the intermediate risk group as clinically homogeneous, even though the set list criteria count for combinations of tumor size, LBSI, and stromal invasion. The group still includes variability in biological behavior and prognosis. And in our study, chemoradiotherapy was more frequently given to patients with non-squamous histology and tumors larger than 4 centimeters, and likely was reflecting the perception that these subgroups carry a higher risk. However, when we looked at those same patients after matching, we found no survival benefits associated with chemoradiotherapy. And that brings me to the second part of the question. So yes, I do believe treatment decisions should vary depending on whether a patient has 1, 2, or all 3 risk factors, which is in fact what the set list criteria attempt to capture. However, this level of granularity is difficult to assess in retrospective datasets, even though it's highly relevant in clinical decision making. And finally, some recent trials, such as Cervantes, are beginning to explore more refined risk stratification models, incorporating additional parameters, for example, like tumor-free distance. And there are also coming up nomograms that are being currently developed to support individualized decisions, but none of those tools have yet been prospectively validated, unfortunately.
So now, on the terms of side effects, obviously, when you combine therapies, there's always a concern for the side effect and toxicity profile. So Stephanie Gill from the University of Toronto, she's asking, was there any data available on treatment side effects? Although there was no difference in overall survival, if there is also no difference in toxicity for chemotherapy versus chemoradiation, do you think providers would still add chemotherapy? In other words, if there's no difference in toxicity, why not do 2 treatments rather than just 1 treatment?
Unfortunately, like I said before, specific chemotherapy-related adverse events are not collected in the database. However, we know that those side effects of using chemotherapy have been previously reported, not only from retrospective, but also from prospective studies. And the use of concomitant chemotherapy doubles the risk of grade 3 and 4 adverse events, hematological and non-hematological. So I think that in clinical practice, no intervention without proven benefits should be added to the standard of treatment. And that's why chemotherapy in this scenario should be avoided.
Very well. So now, Julia Gellison from the University of Wisconsin-Madison, she wants to know about death of stromal invasion and, certainly, again, information that might not have been available in the database. But Núria, she wants to know, do you think that your outcomes would have differed if you had information on death of stromal invasion?
Yeah, this is in fact a very valid question. Depth of stromal invasion is part of the original setlist criteria. And yes, I would say that ideally we'd like to have that information. But honestly, I don't think its absence meaningfully weakens our findings. The classification we used based on tumor size and LBSI is not new. And in fact, it's a practical and previously published approach that has been applied in other studies using also the National Cancer Database. But most importantly, if we look at prospective data, the GOG 263 trial, where stromal invasion was included in the cohort selection, chemoradiotherapy didn't show a significant advantage over radiotherapy alone in terms of recurrence-free survival, which was the primary objective, or overall survival. So yes, of course, having depth of invasion would have allowed for more detailed risk stratification, but given what we know from also prospective evidence, it's unlikely that it would have altered the main conclusions of our study, and the overall message should remain consistent.
David, the question from Thomas Bartel at the Medical University of Vienna is referring to mortality rates, and he's asking, in comparison to data from the EMBRACE and the LAC trials, a 15% mortality rate at a median follow-up of approximately 5 years appears high. How would the authors explain the reasons for these discrepancies?
The populations included in those trials are not comparable to the population of our study. Specifically, in the LAC trial, patients with not only intermediate risk, but also high risk, but predominantly low risk disease were included, as less than 30% of patients required adjuvant treatments, compared, of course, to 100% of the cohort that we used for our study, which certainly could improve the oncologic outcomes reported in the LAC trial. Regarding the EMBRACE studies, outcomes also depend, of course, on the patient population chosen for comparison, as some studies include patients with early locally advanced disease, while others are focused on locally advanced stage cervical cancer. And as expected, for example, for those patients included in EMBRACE studies, including patients with higher stage disease, they have actually worse overall survival outcomes compared to our study population, which excluded all patients with locally advanced or high-risk disease. So I think those populations at the end are not comparable.
Núria, I'll turn to you. Several of our fellows, Christian Braun from Lucerne Hospital and Kyra Fisher from the University Hospital in Heidelberg, they were interested in patterns of recurrence. And their question is, given that your study focused on overall survival, is information on recurrence, particularly recurrence patterns, available in the National Cancer Database? And if so, are there any plans to explore whether recurrence patterns differ between patients who were treated with radiotherapy alone versus chemoradiotherapy?
Yes, so unfortunately, as was previously also mentioned, the NCDB does not collect data on recurrence or recurrence patterns, and we clearly acknowledge that this is a major limitation of our study. But that said, I do believe it would be valuable to understand how and where patients recur, especially when comparing treatment strategies. We focused instead on overall survival, which, while not perfect, remains a highly relevant point. And it's true that overall survival may not exclusively reflect cancer-related mortality. However, in the end, what matters most is not just whether someone recurs, but also whether patients are alive after treatment. And in fact, to reduce the impact of long-term unrelated deaths, we specifically looked at 5 years overall survival, a widely used benchmark that captures the time window when most disease-related events are expected to occur. And we did not find any significantly differences between patients who received radiotherapy alone and those who received chemoradiotherapy, as both groups had a survival rate of 87%. So while overall survival is not a perfect substitute for recurrence data, it might remain a practical endpoint, and particularly in large population-based study like this one.
David, Julia Gellison from the University of Wisconsin in Madison, she's asking, keeping in mind that this study could not assess recurrence-free survival, do you think there are any differences between your study and the systematic review that you cite in your introduction that may account for the fact that they found a recurrence-free survival difference with chemoradiotherapy, but this study did not find that difference with chemoradiotherapy?
That's a great question. We always ask ourselves when we're starting a new project if it's going to be good to assess something that has been previously assessed in a retrospective way. And of course, the systematic review is so good to share that example. There are several important considerations when we compare our study with that previous systematic review. First, the systematic review, unfortunately, included studies with not only cervical cancer limited to the cervix, which should represent the true intermediate risk group as defined for the IJGC trial, but also locally advanced disease, including vaginal and parametrial invasion as part of the studies that were included. And additionally, the meta-analysis combined data from retrospective cohort studies with information from randomized control trials. Nonetheless, like our study findings, the review reported no statistically significant differences in terms of overall survival, which is the same outcome that we have between patients treated with concomitant chemoradiotherapy and those receiving radiotherapy alone. So the same, it's kind of the same result.
I want to turn to Núria. This question comes from Christian Braun. And he's asking, noting in your study, you used the National Cancer Database to identify patients with intermediate risk cervical cancer. Were you also able to identify a comparable cohort meeting set list criteria that did not receive any adjuvant therapy? So if so, are there plans to explore overall survival differences between patients who received adjuvant treatment and those who did not? So never mind chemoradiotherapy versus radiotherapy alone. How about no treatment versus some treatment?
Yeah, this is also a great question. In fact, this specific question has already been explored in our previous NCDB study, and they specifically looked at patients with intermediate risk cervical cancer, defined similarly to our criteria, and compared overall survival between those who received adjuvant radiotherapy and those who were simply observed after surgery. And interestingly, they found no significant survival difference between the two groups. And that's part of the reason why the benefit of even giving adjuvant radiotherapy alone in this setting is still being debated. And to address, in fact, that question prospectively, there's an ongoing randomized trial, Cervantes trial, that aims to clarify whether observation might be a valid option.
Wait, Núria, you have to open the door.
Oh my God.
Wait, Núria, stop.
Okay.
Wait.
What happened?
Oh,
My door.
Arthur, help us.
Yeah, but honestly, from my side, the internet was well.
Núria, you have to open the door.
David,
No, I was listening perfectly. I think it's Pedro's door.
yeah. It's your wooden door. Because from my side, it was okay.
Oh man! So
or the glass behind you. Or the glass behind you.
All right,
you need some
go
air.
open the door.
I thought that you didn't like the Cervantes trial. That was
I saw that.
Please don't mention Cervantes.
Stop, Cervantes again, no.
Cervantes.
This is like, wait, hold on. Let me see. Let me go somewhere differently here in the room. Oh my God. Let's see. Open the window. Can you hear me now?
Yeah.
Yeah, perfectly well.
Like now Arthur froze.
No, but I
Not
think
for us, I think.
yeah.
All right, cool. So, sorry, Núria. Just
No problem.
when Arthur goes like this, start the answer because it was basically when you started. So
Okay.
Yeah. So
Pedro, I was going to ask you something. You know, the question that Núria was answering and the next one, it's kind of the same. I don't know if you want to skip
yeah,
the other one.
totally. Yeah, I was looking at exactly that also. Yeah. So
Okay, great.
so we'll wait for Arthur.
okay, so 3, 2, 1.
Yeah, so this is a great question. In fact, that question has already been explored in our previous NCDB study, and they looked at patients with intermediate risk cervical cancer, defined similarly to our criteria, and they compared overall survival between those who received adjuvant radiotherapy and those who were simply observed after surgery. And interestingly, they found no significant survival difference between the two groups. And that's part of the reason why the benefit of even given adjuvant radiotherapy in this setting is still being debated. And to address that question prospectively, there's an ongoing randomized trial, Cervantes, that aims to clarify whether observation might be a valid option for selected intermediate risk patients after adequate surgery.
So, Núria, obviously published in a very reputable journal, and again, congratulations to you and the rest of the group. But what do you see as the limitations of this study?
Yeah, of course, there are also limitations. Specifically in this study, one of the main issues was the need for multiple imputation to manage the missing data, especially for LBSI, which was an inclusion criterion. And another limitation was the lack of detail on chemotherapy regimens. So we know whether chemo was given, but we don't have information on the specific drugs, timing, or the clinical reasoning behind each decision. And to reduce variability, we excluded patients who received multi-agent or neoadjuvant chemotherapy, but we can't completely eliminate the risk of selection bias since we don't know why some patients received concurrent chemo and others did not. And some other limitations have already come up during other questions previously, like the fact that stromal invasion is not collected in the database, and also, as previously mentioned, the database doesn't provide recurrence data, which limits our ability to assess the true benefit of adding chemotherapy in terms of disease control. And finally, this study, it's not designed or powered to detect small differences in overall survival. So while our findings are consistent and might be reassuring, they do not to be interpreted within that context.
So then to that end, where my last question to you, David, comes from Manuel Montesinos Albert in Valencia, Spain. What implications does the study have for future research directions, particularly regarding treatment de-escalation and patient selection for adjuvant therapy?
I think that the most important reflection from our study is that interventions that could be potentially morbid for patients should not be included as a routine in clinical practice until a benefit is proven in well-conducted trials. There are some interventions that have been used based on assumptions from other populations or other scenarios, and even considered in guidelines recommendations as the use of concomitant chemotherapy in patients with intermediate risk cervical cancer before its assessment in a randomized controlled trial. Moving forward, it would be crucial to identify whether within this intermediate risk group there are specific subgroups defined, I don't know, a certain clinical or pathological risk factor that may benefit from treatment at all, and particularly for the use of chemotherapy in this scenario. stratifying patients more precisely could help us avoid over-treating patients in low-risk populations, while offering, of course, additional treatment options for those who could have a higher risk. We think that de-escalation of treatments based on well-conducted trials or studies should be a priority for our specialty.
So now, Núria, as a last question to you, this one comes from Stephanie Gill in the University of Toronto. Would you recommend de-escalating treatment protocols now, or should we wait for the results of GOG 263 and perhaps speak briefly about what that study is for our audience? And how do you think your findings should influence clinical decision-making today?
Yeah, sure. So the preliminary results of GOG 263 have been recently reported, in fact, in ASCO 2025 meeting. We don't have the final manuscript, though. And they strongly support the idea of treatment de-escalation for intermediate risk patients. As a reminder, this was a phase 3 randomized trial comparing adjuvant radiotherapy alone versus concurrent chemoradiotherapy in patients with intermediate risk early-stage cervical cancer who had undergone radical hysterectomy and lymphadenectomy. And the trial's primary endpoint was recurrence-free survival, and the results showed no statistically significant differences between the two arms. So what did stand out, though, was the increased toxicity in the chemoradiotherapy group, particularly grade 3 and 4 adverse events, and including hematological and gastrointestinal side effects. So we now have high-level prospective data showing that adding chemotherapy does not improve survival outcomes, but it does increase treatment burden, and our own study aligns completely with these findings.
Well, I want to thank you both for an excellent conversation and discussion. I want to congratulate you and your co-authors on this publication. Always learned so much from speaking with you both, and I want to thank you both particularly for the contributions you have made in the field of gynecologic oncology, and we certainly look forward to future contributions from you both. Thank you so much.
Thank you so much for having us. It was a pleasure.
Thank you so much. It's a pleasure for me as well. Thank you.